So let's start. Hello, ladies and gentlemen. Greetings from Shenzhen, China. I'm here in China, and it's 5 p.m. of Peking time. But I know you're from the worldwide, so I'd better say good day. And my name is Fendi. I'm the presenter today, and I have been working in the area of cardiovascular biomechanics for about 7 years. And I just finished my postdoctoral research and came to RainMed in the medical department. So I'm so glad to have all of you here, and I'm looking forward to learn a lot from everyone during the webinar. During the past 2020, RainMed have held multiple webinars successfully. Hundreds of doctors, physicians, and medical device distributors have attended our webinar to share their experiences and opinions. In our webinar, we can have heated discussions about the emerging technologies and the clinical trials of conventional cardiology. And here the webinar can provide us a more accessible and convenient platform for us to communicate directly and share the state-of-the-art knowledge of the innovation of healthcare. RainMed is, as you know, is always dedicated to bring healthcare innovation and making a real difference to people's lives. CFFR is our flagship product and featured as accurate diagnosis rate, free of Addison and no need for guide wire. It's a fast-paced and accurate diagnosis approach for doctors to evaluate the cardiovascular artery ischemia, and which is a perfect substitute for wire-based FFR. Positive feedbacks and appraisals from various hospitals have given us a strong confidence and determination to make CFFR available to more and more people suffering from cardiovascular artery disease. So today we open this webinar, and we are fortunate enough to have Professor Huo Yunlong from Shanghai Jiao Tong University from Shanghai to give us a peer-reviewed introduction about a new research result of our company. So it's called resting indexes of coronary physiology. Professor Huo has been dedicated in the area of coronary biomechanics related to stenosis, hypertension, and heart failure for over 20 years. And he's also the founder of our RainMed Medical, who designed the CAFFR system and now is focusing on microcirculation disease to eliminate the use of pressure wire and technical errors, and it can potentially increase adoption of physiological assessment of coronary artery stenosis. And during the presentation, you are welcome to ask any questions, and you can leave your questions in the live chat. We will collect them and later we'll have them answered. So let's leave it to Professor Huo. Welcome.
Thank you, Fendi. Can you hear me?
Yes.
Yeah, let me introduce myself. First, Fendi is my PhD student and also my master student and my postdoc. Now she worked with in my company. It's a long time not to speak English. I almost forgot to speak English. Oh, long time. I briefly introduce our company. Now our company has almost 200 persons, and we have a very good market in China. Also, we are developing very fast in China. In the world, we have the COVID-19. We cannot go outside. to build up our market in Europe and also in USA. We have to use a webinar to explain and introduce our new product and our old products and our many new ideas. This webinar, I will introduce I will introduce my old product, the CAFFR, and also that's coronary angiography derived FFR, and also I will introduce the coronary angiography derived DPR and CA and the coronary angiography derived IMR. Let's start. Hello everyone. I'm very interested in talking to everyone and introduce my products. Our system we call the angiography. Wait second. Maybe I made a mistake. Can you see it?
Yes, we can see it now.
Yeah,
Thank you.
that's wonderful. Our system we call the angiography-based FFR system, but maybe in the next step, I want to change it, just like a flash system. I call it flash system because angiography-based FFR system, we only include the CAFFR, but we also have the CADPR and the CAIMR. Today, my topic is the resting index of the coronary physiology. I'm Yunlong from Shanghai Jiao Tong University. I'm a professor in the Peking University First Hospital. I think everyone knows in the cath lab, every doctor is using the angiography to determine the PCI strategy. Normally, it's based on the severe of the stenosis. If the stenosis is larger than 70%, they will carry out the stenting. If they met some very complex case, the doctor will use IVIS or OCT to help to improve the anatomical strategy. Normally, I call it morphometric strategy because it's based on the morphometry of the coronary arterial tree. But the ischemia, it doesn't only come from the epicardial stenosis. So we have to determine the physiological strategy. This is very important. Physiological strategy means the FFR, the fractional flow reserve, can characterize the myocardial ischemia. If the myocardium has very severe ischemia, we should carry out the stenting. But FFR needs some the adenosine to get the maximal hyperemia. In Phillips and also the Opens, also the Abbott, they propose IFR, DPR, and RFR. Those are we call the resting index of the coronary physiology. Also, we have the index of microcirculatory resistance. We call the IMR. This one is from the Professor William Phelan in Stanford University. I will introduce them step by step. We know patients with lesions that cannot induce ischemia have a much higher rate of death and myocardial infarction than patients with non-induced myocardial ischemia lesions. So it's very important for us to identify the myocardial ischemia. From this case, you can see the average annual heart events. That means the death or myocardial infarction is very high in patients with abnormal FFR. So today I will introduce three kind of products. The first one is a coronary angiography-derived FFR. We call the CAFFR. Some Chinese doctors call it car FFR. I think it's car FFR are still good for me. Also, we have the coronary angiography-derived DPR. We call the CADPR. DPR means diastolic pressure ratio. Also, we have the CAIMR. I will introduce them step by step. First, let me introduce FFR. I think everyone knows FFR, so I will not describe the definition of the FFR. But we know the FFR is measured in the maximal hemodynamia. Normally we use the pressure wire to determine the FFR. FFR is smaller than 0.8. Normally we can say it had a myocardial ischemia. FFR larger than 0.8. We have the low possibility of the ischemia because the sensitivity is larger than 90%. FFR very important because it can improve the patient outcomes. Also, it has a significant resource saving. So it has very important clinical benefits. But in the world, I think in US is good because they have the almost 30% PCI. They use a pressure wire to determine the FFR. But in other countries, Europe is also good because in Europe, FFR occupied 20%, I think so. But you can look at China, it's only 1%, even lower than 1%. So recently in China, we have a very good market. Our company is growing very, very fast. And the uptake of the FFR remains low in coronary cath lab. The main reason is what? Because we have to use a pressure wire. The pressure wire has a lot of problems. First, it has the pressure drifting. And in 2007, when I was in US, I used a pressure wire. I found the pressure wire, if the pressure wire is close to the vessel wall, it has some effects. Also, the FFR, we need to inject adenosine to induce a maximal hyperemia. So the uptake of the FFR remains very, very low in China and other developing countries, except for the US and also the Europe. Europe, mainly in the developed industrial part. In RainMed, we developed the angiography-derived FFR. Angiography-derived FFR normally just based on the angiograms from two projections, we can calculate the FFR value. In the world, there are three products. I think now maybe Pi has his VFFR, but the most popular is the QFR, that's from Medis, and also FFR Angel from Castworks, and also CAFFR from RainMed. That's my company. The difference between the QFR, FFR Angel, and the CAFFR is the basic method. They are different because QFR using the mathematical formula, and the FFR Angel using the elemental system. They simplify the Navier-Stokes equation. We use a CFD, we use a computational fluid dynamic model to calculate FFR. We got very stable FFR value. Two doctors can get the same answer, but in China, I know, two doctors carry out the QFR. They got two different values. Also, the FFR, I don't know FFR Angel because we didn't perform FFR using the casework system, because casework system is only in US and Israel and also in Europe. The advantage of the angiography FFR is no need for wire manipulation and no hyperemic stimulus. Now I introduce our CAFFR. Our CAFFR we call the coronary angiography derived FFR. From the angiogram, in angiogram from two projections, we can 3-dimensional reconstruction of the coronary arteries from the inlet to the most distal value to the most distal position. And then we can use a T-mean method to determine the flow velocity. Also, we have our own pressure sensor is connected to the outside. You can look at it. It's connected to the outside. We can determine the aortic pressure wave. We input the flow velocity and also the 3D reconstruction of the coronary arteries and also aortic pressure wave into our console. In our console, we can utilize a specially designed CFD model to determine the CAFFR value. Why I emphasize the CFD model? Because when the epicardial coronary arteries, if we have a stenosis, this stenosis can have 3-part pressure drop. The first part pressure drop happened in the entrance lens. The second part is the fully developed lens. The final part is from the distal part, because the distal part we have the flow vortex. The flow vortex we have the flow separation, stagnation pump flow, and also flow reversal. But if the stenosis is very short, we only have the entrance lens. If the stenosis is very long, we have the entrance lens and the fully developed lens. So based on our sensitivity analysis, I found, this is from my previous publications, I found the diameter of the stenosis can affect the pressure drop 45%. And the flow velocity can have the 35% effects on the FFR value, and the aortic pressure and the length of the stenosis, they have the 10 to 20% effects on the pressure drop. So everyone is very important. We should know the distal CSA, stenosis length, flow rate, stenosis diameter can affect the pressure drop across the stenosis. So we have to use a computational fluid dynamic model, because computational fluid dynamic model, we can use a mesh to we can mesh the 3D reconstruction the coronary arteries. So we can use a computational fluid dynamic model to calculate the pressure, flow velocity in each point of the mesh. So we carry out the Flash 1 clinical trials. I think most of the friends, you know these clinical trials. We evaluate the CAFFR compared with the invasive wire-based FFR in 328 patients. This part, we have the accuracy is close to 96%. And the FFR in the gray zone, this gray zone we call the FFR larger than 0.75 and smaller than 0.85. The accuracy is 90%, But if we exclude two myocardial bridge, our accuracy is 91%, even in the gray zone. This one is a relationship between the CA-FFR and the wire-based FFR. Now I have a brief summary for the CA-FFR because this one is no need for wire manipulation, no hyperemic stimulus, much faster than wire manipulation and more accurate than CT-FFR because we also have another product is a CT-FFR. We use our CT-FFR and our CT to match our robotic, and that's different. That's our future product. But this part of the CA-FFR will still need to use an empirical model to compute the hyperemia flow from the resting blood flow. This part we can induce some maybe computational error, especially in the gray zone. So if we don't want to use the empirical model, we have to consider about the IFR. IFR from the DEFIN and the Sweden heart experiment, the clinical trials, we know the IFR is very important. IFR is the average PD over PA during the wave-free period. You can look at the part. This period is a wave-free period. Is different from the total period over the cardiac cycle. So the IFR is still in the rest. So IFR we call the resting index of the coronary physiology because we determine it in the baseline. It's not in the maximal hyperemia. IFR with a cutoff 0.89, non-inferior to the FFR with a cutoff 0.8. Also, IFR guide strategy is super to the FFR strategy in terms of cost effectiveness, and no hyperemia stimulus, and also faster than FFR. But IFR still needs a pressure wire to measure the distal pressure, and also it has a problem from the pressure drifting and another problems. The DPR is very the DPR is average PD over PA. PA is the mean aortic pressure during the entire diastole. From the figure, you can look at the DPR means in this range is the entire diastolic period. But the FFR is only in the wave-free period. The DPR has a larger period it's a longer period than the wave-free period. But many experiments, many clinical trials have proved the DPR equals to FFR. When DPR with a cutoff 0.89, IFR has a cutoff 0.89. They have the equivalent. They have the numerical equivalence. Also, the other company like the Abbott, they propose the RFR and BXS, the DFR. All of them, they have the same cutoff, 0.89. They have non-inferior results to the FFR with a cutoff 0.8. So those resting indices is still good, but the operation time is not so fast because we have to put the pressure wire into the coronary arteries. So our company developed a new product, also we call the CADPR, that's coronary angiography derived diastolic pressure ratio. We also from the diagrams from the angiograms from two projections, and also aortic pressure waves. From the aortic pressure waves, we can determine the diastolic period In the diastolic period, we can determine the flow velocity in the diastolic state. And then we put the diastolic flow velocity and also the aortic pressure in diastolic state, and also the 3D reconstruction into the flash angio console. In this case, we can determine the CADPR. And we don't have enough DPR measurements or IFR measurements to validate our CADPR. So we have to use our previous wire-based FFR to validate our CADPR. From the table, you can look at our diagnostic accuracy is still very high. It's close to 87.7, but in the gray zone, that means FFR larger than 0.75, smaller than 0.85. That there's not diagnostic accuracy is only 73. This one is very consistent with a comparison results between the DPR and wire-based DPR and the wire-based FFR. That means our CADPR is reasonable. We will still need more clinical trials to validate our CADPR. This point, you can look at the relationship between the CADPR and the wire-based FFR. They still have a good correlation. Also, we can see we don't need the wire manipulation. We don't need the hyperemia stimulus. This one much faster than wire manipulation, and the CADPR can improve the hemodynamic assessment of coronary lesions. But this part, we need more investigations. Especially, we need to use a wire-based DPR or wire-based IFR to validate our CADPR. And also, we need to use long-term clinical trials to validate the CADPR, the long-term the CADPR results. Is that benefit or not for the physiological assessment? Recently, we know the microvascular disease is very popular. When we go to the cath lab, more than 70% patients has a microvascular disease. How to evaluate the microvascular disease? If we have for the INOCA patients, that means those patients has a normal epicardial coronary arteries, but they still have the angina. That means most of the case they have the microvascular angina. The microvascular resistance should be very high. But in this case, we can still use CFR to evaluate. Based on my previous experience, I found the CFR is unstable, but the microvascular resistance, the IMR is very stable. IMR is proposed by Professor William Faven. IMR larger than 25, that means this patient has a microvascular disease. But this part, I only want to emphasize, this kind of part is only the adenosine-induced microvascular disease. If you want to evaluate the epicardial vasospasm or the microvascular vasospasm, you have to use acetylcholine. But this time acetylcholine test is very dangerous in the cath lab. Most of doctors doesn't use it. I want to emphasize the IMR. IMR equals to the PD. PD means the distal pressure in the maximal hyperemia. TMN is a time passing the pressure wire. Is inversely proportional to the flow velocity passing this point, passing the PD point. We found Professor William Faven found the IMR is very important, especially for the abnormal stress test, but has no significant epicardial coronary lesions. Those kind of patients we call the INOCA. Also the successfully PCI, but ongoing angina. All of those part, the cutoff for the IMR is 25. That means larger than 25, the patient has a microvascular disease, but smaller than 25, the patient had no this kind of microvascular disease. Another very, very important application of the IMR is a patient who has a acute coronary syndrome. And we have in China, no, most of this case, we have to carry out the stenting. We have to stenting the patients. After the stenting the patient, we need to measure the IMR. After we measure the IMR, if IMR larger than 40, those patients is very dangerous. Normally in 1 year, clinical trials, we have the more than 40% patients have the myocardial infarction or the because of come back to the hospital due to the myocardial infarction or the heart failure. It's very, very dangerous. So we have to use the IMR to determine how can we treat those patients, especially this patient with acute coronary syndrome. Also, in the patient after heart transplantation. In my own point of view, I think the patient after TAVI, they still need to using IMR to estimate the coronary microvascular disease, because TAVI has a very similar results like the heart transplantation. That's my own point of view. You can give me more suggestions after the talk. Also, the IMR, we have the definite CA-IMR. We propose a CA-IMR, that's a coronary angiography derived IMR. This part, we don't need the maximum hyperemia. We still determine it in the baseline. Same to the CA-FFR and the CA-DPR. The angiograms from two projections with angles larger than 30 degrees. We have the 3D reconstruction of the coronary arteries. Also, we have the flow velocity as a diastole. Here, I want to emphasize, we have the flow velocity as a diastole, like the CA-DPR, because the flow velocity in the over the entire cardiac cycle is different from the flow velocity as a diastole. Also, we need to the aortic pressure wave, and we need the CFD model. This aortic pressure wave, we can determine the diastolic period, the mean value of the diastolic pressure ratio, the diastolic value. The CA-IMR equals to PA, that means the PA hyper in the diastolic part, and times CA-FFR, and then times L equals to 7.5 centimeter, and then times K time, and then divided by K times V diastole. K is from the previous literature and clinical data. In the INOCA patient, K equals to 2.1. In the patient with acute syndrome, K value is significantly reduced. First, we use a retrospective study for assessment of the CA-IMR. The paper is also published in Frontier in Physiology, just published. We evaluate diagnostic performance of the CA-DPR compared with the invasive wired IMR, because the CA-IMR we should validate by the wired-derived IMR. Some doctors suggest me to use MRI or to use a SPECT to validate the CA-IMR. We found it's not good because wire-based IMR doesn't match the MRI and doesn't match the SPECT, not so good because accuracy only is 60%. We evaluate the CA-IMR using the invasive wire-based IMR in 56 patients with INOCA. Stable angina pectoris occupied 60%, unstable close to 30%. Those patients no previous myocardial infarction. Also, the silent ischemia occupied 5.4%. Here is a relationship between the CA-IMR and the IMR. IMR is from the variable-based IMR. From the figure you can find, it still have a good correlation. Why I call it good correlation? Because IMR has a larger variation. It's from the 8 to 100. This one is different from the FFR. FFR varied from the 0.4 to 1. So the FFR have the figure shows a very good correlation between the CA FFR and the variable-based FFR. But the IMR has a larger variation. So this figure is not perfect. But we use a retrospective evaluation of the CA-IMR, and because we have the results, we collaborate with Samsung Clinical Center. We found the CA-IMR has a very good clinical results like the IMR. That's for the 1 year results. 1 year clinical results after PCI in patients with acute syndrome. Here is that I have a brief summary for the CA-IMR. Exactly same to the CA FFR and the CA-DPR. We don't need the wire manipulation. We don't need the hyperemia stimulus and the faster than wire manipulation. Also, CA-IMR is very useful for physiological assessment of the microvascular disease in patients with ischemia heart disease. But this one, we still need more validation. And now we validate our CA-IMR in INOCA patients, and also we validate our CA-IMR in patients with acute syndrome. But that paper in the acute syndrome patients, the paper doesn't publish. But we hope we can publish in the following year, maybe in the January or February. Finally, thank you everyone. But I have the final suggestion is I think a combination of the CA-FFR and the CA-IMR will have maybe more. We will have a good hyperemia, good physiological assessment. I think so. We need a combination of the CA-FFR and the CA-IMR. But CA-DPR, in my point of view, I don't know how to use it still, honestly. Thank you, sir. Thank you, sir and madam.
Thank you, Professor Huo. Thank you for a wonderful presentation. And I think it certainly gave us a better understanding of the advantages of our wire-free FFR. And we are looking forward to move on to the next step to the clinical trials and to verify the function and the use of our new product, CA-DPR and CA-IMR, to facilitate our present product to give a novel tool for the doctors to diagnose their ischemia. And we are looking forward to have more collaboration with other doctors and hospitals in the worldwide to verify our product. And next, we can we have 5 minutes break, during which we want to show you a video for you to know us better. And you can ask any questions in the live chat, and we will later have them answered. We will also send you a questionnaire link, and you can and please kindly fill in and give your feedbacks and suggestions. So, Nick, can you send the video? Okay.